We are moving into the stomach, and before moving into the stomach, let us see the transition zone. Okay, these are transition zones. You have to remember. One I told in the lip, other one it is esophagus and stomach. The third one is stomach and duodenum. The fourth one is ileum and cecum. The fifth one is rectum and anal canal. There are 5 junctions in the GI tract, starting from the mouth to anal canal.
Figure 12.6 esophageal stomach junction, stain, hematoxin and mucin. On low magnification, we are seeing stratified squamous epithelium on esophageal
First,
part.
you see the esophagus and stomach. Okay, I will draw a line. So, this is esophagus, and this is stomach.
In esophagus, we are seeing stratified squamous epithelium, lamina propria, esophageal cardiac glands, excretory duct, muscularis mucosa, excretory duct, esophageal gland proper, submucosa, muscularis externa.
Super.
And on stomach, we are seeing gastric epithelium, gastric pits, lamina propria, mucous neck cells, parietal cells, zymogenic or chief cells, gastric glands, cardiac glands, muscularis mucosa, submucosa, blood vessels, and muscularis externa.
Even though they have shown parietal cells here, can you see the cells that are having like a fried egg appearance? These are the parietal cells. These are large cells with a distinct cell border, abundant granular eosinophilic cytoplasm, centrally placed vesicular nuclei with uniformly distributed chromatin. So, this is how you have to describe the parietal cells. Please remember in your description, cell border, cytoplasm, quantity and quality, nucleus, quantity and quality. That's the way to describe the individual cells. And you see these cells, cardiac and fundus, are made up of predominantly this type of cell. These are known as foveolar cells. They are tall columnar cells with a basally placed nucleus with abundant mucin in the top. And please see, there are no goblet cells. If you see goblet cells in the stomach, it is intestinal metaplasia. And this type of foveolar epithelium you may see in the duodenum, especially second part of the duodenum. Then it is gastric heterotopia or ectopic gastric gland in the duodenum. Small intestinal mucosa can come into the stomach, or the gastric mucosa can be seen in small intestine. That you have to remember. Then we call them metaplasia.
Figure 12.7 esophageal stomach junction, stain, malaria and esophagus, we are seeing stratified squamous epithelium, lamina propria and muscularis mucosa. On stomach, we are seeing simple columnar epithelium, gastric pits, gastric glands and lamina propria.
Stomach, fundus and body regions, transverse section, stain, HNE, low magnification. Stomach is divided in mucosa. We can see the surface epithelium, lamina propria and muscularis mucosa.
Okay.
Then there is submucosa and muscularis externa. In muscularis externa, there is an inner oblique muscle layer. Then there is a circular muscle layer. Then there is an outer longitudinal muscle layer, and then serosa, visceral peritoneum. And we can see rugae, gastric pits, surface epithelium, lamina propria, parietal cells, chief cells, together gastric glands, muscularis mucosae, lymphatic nodule, collagen fibers, arteriole, venule, submucosa consisting of Meissner's nerve plexus, capillaries, myenteric Orbach's nerve plexus, adipose cells.
Uniform size, shape and distribution. I call it as SSD. This is very important. Uniform size, shape, distribution. What I mean by that, when you see lines along them, they are all very uniform. They are all uniformly shaped and uniform. Even here, there is some dropout. It has to be one more gland like that. So these are all uniformly distributed. Any disease process, there are 2 things that can happen. One is architectural change. Other one is cytological change. These 2 things are the criteria for pathology diagnosis. Changes in the architecture, changes in the individual cell. That is known as cytology. And changes in architecture is very, very important, especially in GI tract, in chronicity. In general, what do you mean by chronicity? 6 months is the chronicity. For example, if you read hepatitis, they may say abnormal liver function test for 6 months. Chronic diarrhea, abnormal for persisting for 6 months. What happens when there is, and this is predominantly for inflammatory condition, it's not for neoplastic. Neoplastic can take years, can take only weeks, can come in days, we don't know. But when you consider the medical diseases like gastritis, colitis, enteritis, hepatitis, 6 months is an important number you have to remember. What happens in these 6 months? There will be lot of ulceration, there will be regeneration, there will be ulceration, there will be regeneration. And when there is repeated insults for 6 months, the architecture will be lost. There is no uniform size, shape distribution. That is very, very important for chronicity. The chronicity is decided by architectural changes, because people used to say, if you see lymphocytes, if you see plasma cells, it is chronicity. And in the lamina propria, see, these are all plasma cells. What is the role of plasma cells in GI tract? Remember, we talked about it.
Secretory IgA.
Yes, secretory IgA, SSD disruption. If you want to show it in the cartoonistic way, so this is normal. What happens in chronicity? There will be branching of the glands. Can you see the difference? Second one, and another thing you have to remember, these basal crypts will be sitting on, what am I drawing away the? So this is the muscularis mucosa. And if you go back and see, they will be very nicely sitting over the muscularis mucosa. Can you see the muscularis mucosa here? And when you see it in chronicity, that they won't be sitting on the muscularis mucosa. When you draw the muscularis mucosa here, so you can very nicely see the architectural change. That is number one criteria, architectural change. Number two, basal plasmacytosis, basal plasma cells. Remember, I told you, normally you see the plasma cells in the upper part, whereas here you can start seeing them in the basal portion. And sometimes what happens, they will be crowded in between the base of the gland and the muscle. They will be sitting in between the gland and the muscle, which is totally abnormal. They should not come in between the glands and the muscle. Basal plasma cells, and this is also known as bottom heavy. And number three is granulomas. And number four is increase in certain number of cells, certain WBCs. For example, eosinophils. When you see 5 eosinophils sitting together, remember the number 5 eosinophils sitting together, or if there are more than 15 eosinophils within one high power field, let us see these are eosinophils, so 5 of them are sitting together, or imagine this is the one high power view and you see 15 eosinophils within them. These are all the criteria for chronicity. Granulomas is not a must. And what is the important criteria you have to remember?
The architectural change.
No, in general, there is no single criteria. It's a couple of criteria. You can say there are some major criteria or minor criteria. The important criteria in life you have to remember is there is no single criterion. And this is the only single criterion that has a single criterion. And when will you be happy, as a pathologist or as a doctor?
When I give the right diagnosis and they get treated.
You will be happy? Is there any other step you want to add? See, whenever they are giving right treatment, the patient has to respond to the treatment and symptoms should be less or it is gone. Then only you can be happy.
Stomach mucosa of the fundus and body in a transverse section, stained, hematoxin and eosinophils in a median magnification. On the left side, surface epithelium, mucosal ridges, mucus cells, parietal cells, gastric gland, lamina propria, chief zymogenic cells, small smooth muscle glands, muscularis mucosa, inner circular outer longitudinal layer, then submucosa on our right side, a gastric pit, smooth muscle gland, surface epithelium, and a gastric gland should isthmus, neck, base or fundus, and a lymphatic nodule, fibers, fibroblast, arteries, and venules.
What do you think about the glands, Vinod? You remember, architecture is number one in pathology. If you have this section as a gastric biopsy, you have to say gastric fundic / body mucosa with the uniform size, shape, distribution of the glands. These glands, they are sitting on what? They are resting on the muscularis mucosa. And you see the lymphoid aggregates in between the muscle and the glands. So, this is one of the criteria for chronic gastritis. And another thing here, they have seen the muscles going in. Usually the muscles don't go in. They are all like this only. And when the muscles go in, we have to think of chemical gastritis. For example, whenever the bile comes into the stomach, biliary reflux, and the stomach will try to become duodenum. So, they will have surface villiform changes, lamina propria edema, and muscularization of the lamina propria. The muscle bundles will start coming. There will be hyperplasia of the muscularis mucosa, and these muscularis mucosa will start extending into the lamina propria. That is known as muscularization of the lamina propria. So, now we are seeing the criteria for chemical gastritis. We know the read. What are the criteria for chemical gastritis?
Number 1, villiform surface epithelium. Number 2, lamina propria edema. And number 3, hyperplasia of the muscularis mucosa, and along with muscularization of the lamina propria. Stomach of fundus and body region, plastic section, stain, hematoxin and eosin at 50 magnification. Shows a simple columnar epithelium, gastric pits, parietal cells, and submucosa, right side gastric glands, chief zymotic cells, lamina propria, muscularis mucosa.
Again, uniform size, shape, distribution, and all the glands are sitting on the muscularis mucosa. Acute gastritis, enteritis, colitis, proctitis. They are all the same. Here, there is no architectural change. Acute, there is no architectural changes. But one thing you have to remember, how many patients are getting biopsied on acute? So, pure acute is uncommon in our biopsy setup. What can happen is, there is some chronicity changes with overlapping acute changes. That's why we call chronic gastritis with activity. With activity means overlapping active inflammation is going there, or you can call acute and chronic gastritis. Okay, so that also you have to remember. The acute gastritis, you saw the glands, these are all the cryptepithelium, and when the glands are cut tangentially, they will be like that. I will draw the gland, one of the glands. What is this area in between the glands, Abhijit?
Sir, lamina propria, sir.
Super. And what is this area, red color, which I am drawing?
Muscularis mucosa, sir.
Super. So, you have to remember surface epithelium sitting on the basement membrane, and then lamina propria, and then muscularis mucosa. So, when do you call acute? When there is ulceration in the mucosa, and ulceration should be surrounded by granulation tissue. Or one criteria is ulceration with granulation. Why I am saying granulation also? Because sometimes the mucosa is sloughed off. And if the submucosa or if the lamina propria is normal, it is not ulceration. So, ulceration has to have some reaction to it. Number 2, imagine these are all the neutrophils. The red are the neutrophils. Neutrophils in the epithelium. The neutrophils normally should be in the lamina propria. And as you all know, lamina propria is full of minute capillaries. That's why neutrophils are sitting, and that's why looking at the neutrophils in the lamina propria, lymphocytes in the lamina propria, you should not call it acute or chronic inflammation, and you have to see the neutrophils in the epithelium, and that is known as, for example, in the colon, that is known as cryptitis. And what happens when the activity is more, these neutrophils coming from the lamina propria, after attacking the epithelium, they will go into the glandular spaces. So that this is like a small abscess within the crypt. That's why it is called as crypt abscess. These three are very important criteria for acute inflammation. Number 4, increased cells in the lamina propria as clusters. When it is scattered, it is not the criteria. They have to be as a clusters. These things you have to grade them. Why you have to grade? The patient may start the treatment and they may not respond, they may rebiopsy. At that rebiopsy, this active and chronic inflammation may be there, and you have to compare it with the previous biopsy. Is it responding and is it becoming less in inflammation or more in inflammation? That's why we do the grading. The active, whatever we give it for active inflammation is known as grading. Grading is activity. Chronicity we call staging, especially in hepatitis. Fibrosis is the chronicity in liver, so we call it staging, and we have to follow usually they follow a 3-scale system. There is one disadvantage. Whenever you use a 3 grading system, most of the people stick to the middle. That's why when you see our reports, not only in inflammation, even in differentiation, they may call it moderately differentiated or moderate activity. That's why people are now moving to 2-grade system. Moderate is not helping in the treatment. 2-grade system, whether it is low grade or high grade. So I love the 2-grade system because that helps in the treatment. There are different criteria used for this 3-grade system. Okay, mild, moderate, severe. What I do is, when a biopsy is showing changes in 1/3 or less than 1/3, I call it low grade. 1/3 to 2/3, moderate. If it is more than 2/3, severe inflammation. For example, gastritis, the chronicity changes are seen only in one piece, then it will be a low grade. Same biopsy from some other patient, there are 5 pieces, and they are seen in 2, I call it moderate. Some other different patient, 5 pieces, the lesion is seen in 4 pieces, then I will call it severe. This is known as rule of third. The 1/3, 2/3 or more than 2/3. It's very easy when you follow only 2-scale system, 50%. If it is less than 50% or more than 50%. Less than 50% mild, more than 50% severe. So this is the rough guide that I use. It may be wrong or it may vary from organ to organ, condition to condition. So you use it carefully by reading the references.
Stomach superficial region of gastric fundic mucosa, stain H&E, high magnification. From the top left, surface epithelium, then basement membrane, lamina propria, gastric pits, gastric glands, that is a neck region, parietal cells, lamina propria, once again lamina propria, blood vessels, mucous neck cells, parietal cells, chief or zymogenic cells, sir.
We saw the criteria for inflammation. Now I want to tell the criteria for dysplasia. How will you describe the surface epithelium, Abhijit? Uniform size shape distribution with a single layer of lining epithelium that are tall columnar with basally placed nuclei and abundant cytoplasm filled with mucin. What happens in dysplasia? Number 1, stratification. And number 2, there is loss of mucin or less of mucin. Number 3, whenever there is lot of proliferation, what will you see? Increased mitosis. And whenever there is very increased mitosis, how the cells die? Apoptosis, individual cell. These are all the 4 criteria for dysplasia. Stratification, loss or less of mucin, increased mitosis and apoptosis. Usually, the mitosis can be seen in the basal portion. Here, whatever I mentioned here, it has to be seen in the surface epithelium. The mitosis should be more in the surface epithelium, and the apoptosis will also be more. Apoptosis, how they look, they will look like nuclear fragments, and they are all eaten up by the macrophages. There will be vacuolation cell with vacuolation showing lot of nuclear fragments. So I told you the dysplasia has to be divided into low grade and high grade. First we will finish the theory portion and then I will draw. One is stratification, loss or less of mucin. So all this will be there in both high grade and low grade dysplasia. What are the things that will help to differentiate? For example, this is a gland. Normally single layer, but this is tumor, so it is multi-layer. So there is stratification. If the nuclei, if the stratification and if the nuclei are seen touching the top of the epithelium, then it is high grade dysplasia. Whereas in low grade dysplasia, there will be some cellular proliferation, but the nuclei may not be seen in the upper 1/3 of the epithelium, stratified epithelium. When you see the nuclei, the stratification, the nuclei will be confined to up to middle 1/3 of the height of the epithelium. When the nuclei are seen at the top of the epithelium, reaching the upper third of the epithelium, it's a high grade dysplasia. In high grade dysplasia, number 1, nuclei reaching the top of the proliferation. Number 2, there is loss of polarity. And when you draw the nuclei, all the nuclei will be in one direction in the low grade. Whereas in high grade, they will be in different directions. Number 2 is loss of polarity. Other criteria will be more architectural. This is an individual gland. Okay, in dysplasia, the individual glands become large, and this is look normal. This is looking like dysplastic. Normally, there is single layer of epithelium. Whereas here, the epithelium will proliferate. And in some areas, when they proliferate, they will go into micropapillae. And what happens, these micropapillae can fuse together. And there is fusion of this micropapillae. When the micropapillae are coming and when they are fusing, they will form cribriforming. There will be empty space here. This micropapillary proliferation here. So there are 3 empty spaces here, 1, 2, 3. And this is known as cribriforming. So that is the 3rd and 4th criteria. Micropapillae, and the 4th one is fusion of micropapillae gives rise to cribriform glands. So nuclei reaching the top, probably loss of polarity, you keep it as 4. Okay, nuclei reaching the top, micropapillae will become 2, cribriforming will become 3, and loss of polarity will become 4. These are all the criteria for high grade dysplasia.